Welcome back, everybody. I think that's 2:30, and it's now time for our panel discussion. So I'm going to briefly introduce the panel chair, who's Dr. Dave Snell. So he's a consultant in anaesthesia and critical care and a senior lecturer for UNZA and academic lead for the MED program between 2013 and 2015. He's also been patiently working as trustee for GADP and also our treasurer. So we're hoping that we'll be able to let him step down in the near future. So that's why we're trying to advertise the treasurer role, but he has done a fantastic job in doing that over the last few years. So he's going to be starting the panel discussion, which is about national surgical strategic plans and lessons from the pandemic. I'll hand over to Dave.
Thank you very much, Emma. And hopefully you can all hear me okay. I've just had to, oh, can you not hear me?
I can.
You can, okay.
Yeah, I can hear you.
Thank you, fantastic. I got a chat message to say they can't hear me. Thank you all for coming back. And I think everybody who's been on this morning's conference will agree it's been a fantastic morning and initial afternoon session so far. So we've got just about an hour together now, and my goal is really to explore within the two main countries that GADP operates at present, so Zambia and Ethiopia, what has been accomplished in their strategic surgical plans over the last 5 years or so, what lessons the pandemic has taught us, and to look at the role of organisations like GADP and CANESCA, as well as others within the strategic plans. I want all of you as the audience to be involved and to put questions up on the text chat as you have done so far. Christine Musadabwe is going to keep an eye on the chat, as I'm sure will Emma. But I'd like you all to think, even now, and potentially write on the text chat what you might want from this discussion, and that can hopefully help us formulate things moving forwards. We have a fantastic panel for you this afternoon, and I'm going to waste no more time in introducing them. So I'll start with Professor Emmanuel Macassar, who many of you will know or have heard of. He's an adjunct professor of global surgery and orthopedic consultant in Zambia. He's the founding director of WITSurg, which is the Witwatersrand Regional Collaboration Centre for Surgical Healthcare Improvement. He also chairs the Southern African Development Community Technical Experts Working Group on Surgical Healthcare, and he's widely presented and published on safe, affordable, universal healthcare, and was previously Zambia's global health diplomat to the UN. Professor Mahalet Tadusu is a general and cardiothoracic anaesthetist and an associate professor of anesthesia in Addis Ababa University, who you heard speak this morning. She's also the president of the Ethiopian Society of Anesthesiologists. Dr. Wyson Munga is a consultant in obstetrics and gynecology. He's the champion for safe surgery and director of the Faraja Diagnostic and Medical Center, and former district director of health for Kafui in Zambia, and former president for the Resident Doctors Association of Zambia. Dr. Christopher Chanda, again, many of you will know on this conference, who's the National Anesthesia Coordinator for the Ministry of Health in Zambia, and a pediatric and adult anaesthetist consultant who works within UTH in Zambia. He's also head of department of anesthesia in UTH. And Dr. Abel Mwale, who is consultant in anesthesia and critical care medicine. He's the president of the Society of Anaesthetists of Zambia and Secretary General for the African Regional Section of the World Federation of Societies of Anesthesiologists. So welcome to you all, and thank you very much for agreeing to be on the panel. It's a fantastic range. So as a point of introduction, I think in response to the World Health Assembly Resolution 68.15, and in line with the Lancet Commission on Global Surgery, the Ministries of Health of Ethiopia and Zambia launched their national surgical, obstetric and anesthesia strategic plans. in the last 5 years or so. And in fact, they were pioneering the way along with Tanzania, with the aims to make essential and emergency surgical and anaesthesia care accessible and affordable as part of the universal health coverage. But I think it's fair to say that the targets were optimistic, with the aim of achieving 20 surgeons, obstetricians and anaesthesiologists per 100,000 population in low-income and low and middle-income countries by 2030. Bearing in mind, this was from a starting point of 1.1 per 100,000 population in Zambia and less than 1 per 100,000 population in Ethiopia. And since then, sadly, as we are all more than aware, the globe has been struck with the COVID-19 pandemic. Now, although this will have set the globe back significantly with regards to some of its sustainable development goals, and it will have pulled resources from much needed areas, including safer surgery, it's also taught us much. And some of this, I think, can educate us and can further enhance us in newer iterations of national strategic plans. So I'm going to start with the first question that I'm going to pose to the panel, and I'm going to start with Professor Macassar, if I may initially, and then Professor Tadusu, looking at what have Zambia and Ethiopia accomplished through their last national surgical, obstetric and anaesthesia strategic plans, but also what has not been accomplished that we wanted to or was meant to. So if I can put that initially to Professor Macassar.
Thank you, David, for the opportunity, and thanks to everybody who has gone into putting this meeting together. Coming to your question, as you know, the Zambian plan was from 2017 and was to run until the end of last year, 2021. And like you rightfully said, the last 2 years were COVID years, and we literally almost did nothing in that regard. But of course, it also presented an opportunity, and I will elaborate. So our plan, though it's difficult to give you with confidence the true achievements, because one, we did not manage to do our midterm review, which was supposed to take place 2.5 years after. We had a partner from a high-income country who was contracted to do it, as an independent reviewer. Something went wrong with that, and we never got that done. And we actually are supposed to do an end of term or end of policy review now that we're just in the early parts of the follow-up year. That would be the best way to actually give you what has been done, what has been achieved, and what has not. So what I'm going to give you is just based from my observation, and it may not be comprehensive. And I note that I have a lot of my colleagues in attendance today, and they can probably speak to that. So what we noted is that the government, starting from 2016, 2015, embarked on a lot of infrastructure equipment and improvements. There were hospitals that were built, especially district hospitals, but I don't think we've managed to build in every district that we have set up. But there was a lot of investment in building hospitals, and there was also a little bit of money that also went into equipment. Again, I can't tell you whether we have gotten all the equipment that each hospital may need to actually provide safe surgery, obstetric and anesthesia, but there was some equipment, though it's limited. And the key thing that I would probably comment on that we have noted that has increased is the issue of the human resources in health. Generally, as we have had a huge output of nurses, medical doctors from different institutions, both private and public, and of course from outside the country. And we've also set up new programs to try and provide new specialists. The COSEXA training has continued with new sites. The STP program, as you know, has also been established and it's up and running. And of course, the MED has continued. And of course, the new university at Levi Mwanawasa also seems to be going into the postgraduate programs. But even with that increase in human resources, what we have noted is that we don't have enough teachers. So we are already noticing a little bit of weakness in the quality of the people that we are churning out, especially the specialized ones. And there is also within the human resource framework a huge shortfall of anesthetists and perioperative nurses. So we don't have enough surgeons, but we do have enough that can actually perform some surgery. But we struggle very, very much every day. Even in the tertiary facility, we keep canceling our cases because most of the time we don't have an anesthetist. So even there, even with the increase in the human resources, the critical teams that we need are still very, very, very limited, and that's a problem. The COVID years also, the last 2 years have also created challenges in terms of taking all the resources somehow away from surgical services to, other ways of supporting life, mostly going into, prevention and a lot of other things. We made some mistakes even with the COVID pandemic because we did not really invest very strongly in the clinical part of it. I think a lot of money went into the public health and very little came into the clinical part. We forgot, or our colleagues who were in charge forgot that the care for COVID patients, actually what creates problems is the critical care of the severely ill, the high morbidity and the mortality that will result. And so there was need to not only build the public health part of it, but there was also need to build the critical, clinical components of it, of critical care and emergency care. And for us in the surgical field, the life support that are needed, or the tools and equipment and investment that are needed to maintain emergency care and critical care are the same things that we need to keep surgical patients alive. We still deal with emergencies in surgery, we still deal with critical care in surgery, and of course the operative care component. And so we've been trying to advocate and see if colleagues can be more comprehensive and also look at the investment that they are making for COVID, that they are the same investment that we'll eventually need to sustain surgical services in the long run. And if these can go to the district hospitals, then of course we'll be killing two birds with one stone. But really what we have seen is that we have critical shortages of even essential medications, even analgesic medications, anesthesia medications. So that's where we are. So it's a mixed bag really. Some progress, and in some areas we really haven't done well. Yeah.
Thank you very much. And Professor Tadusu, from an Ethiopian perspective, how does what Professor Macassar said sit with your experiences?
I think thank you, David. So I share what my colleague from Zambia said. So our strategic plan was developed in 2016. So I mean, it was for 5 years, and it ended in 2021. So we don't have an official review released from the Ministry of Health, so I cannot comment on all the focus areas. But from my perspective, from the anesthesia practice perspective, I can comment on our observation. So from our anesthesia perspective, we had 3 focus areas. So the first was human resource improvement, second was the quality improvement, and the third was improvement in the pharmaceutical and the equipment provision. So when we come to the human resource development, I can say this is the one area where we have significantly done better. So we still have not reached the projected numbers, but we're relatively close, I can say. So initially, 5 years ago, it was there was a severe shortage of clinicians, physicians, as well as non-physician surgical and anesthesia providers. So there was a lot of interest in task sharing and task shifting with, incorporating the non-physician anesthesia providers, the IAs, the emergency surgical officers. So regarding all this, I think this is even speaking from the anesthesiology perspective, this is the one area where we did relatively well. So we did manage to significantly increase our rate of enrollment. We did conduct a lot of advocacy. We tried to partner our existing anesthesiology residency programs with partners from abroad, and improve the quality and make it more attractive for new graduates. So we did manage to secure a lot of admissions, and the other thing we planned was to limit or to minimize our dropout rate, because initially, like anesthesiology, our field, in 2016 there were around, I think, 22 anesthesia providers, physician anesthesia providers, but the anesthesia residency program, it has been there for almost 30 years. And it had been almost stagnant, with very minimal enrollment, with very significant high dropout rate, with anesthesia providers leaving the country. So these were the problems we faced. And when we compare it for the past 5 years, I think we did manage to significantly increase our enrollment as well as decrease our dropouts. And this is just mainly by trying to improve the quality of the education, try to advocate for the practice, try to make it recognizable. And this was relatively, it's a work in progress, but we're in a good pace, I can say. The other thing is, we have the second main focus area was the quality improvement. So this is both improving the quality of the program, the teaching program, as well as improving the service. So in this area, I think we still have a long way to go. So we are trying, of course. So some things we did achieve for improving educational quality was we did manage to revise the curricula, get a harmonized national curricula, get a national standard, minimum standard for anesthesia service, as well as anesthesia school for the new anesthesia schools to open. So these things we did manage to get it, but still we do have a long way to go, I would say. Improving the service, again, the same thing. We're still in the work in progress. We're trying to get guidelines and protocols in place so that we can have a minimum safety for anesthesia. But I mean, it's still, we still have to work on that. The other thing to improve our services, we have to develop, evidence-based practice. So developing KYs for perioperative care and having regular audits. These are the things which we still have to work on, I would say, but we have started at least. So these were some of the things we try to improve the quality. The other, and of course, our most significant hurdle would be availing pharmaceutical and equipments. So this is our biggest problem, I would say. Again, even COVID did bring some opportunity by focusing the health investment into securing, this life-saving and essential equipment. And
I think you've just gone on to mute, Mahala.
we still have to work on. We made sure that essential anesthesia drugs and equipments are included in the national drug list. But again, the problem is, the supply chain management is not very efficient. So we're still having shortage in pharmaceuticals and equipments, and we have to make our working environment safe, both for the anesthesia provider as well as for the patient. So this is one area we really have to work on. Otherwise, the human resource, it's in a good pace, and we have to keep on this current pace we have expanded our teaching institutes. I mean, we have not reached the projected for the 2021, but we are almost more than 80% has been fulfilled. So right now we have to work on getting the infrastructure well optimized. And because after a few years, even with all the number of graduates we have, we wouldn't have enough hospitals to absorb all these graduates. So I think that's the main focus area we have to work upon.
Interesting.
In going forward.
Thank you very much. That's fantastic to hear from the two of you, and in some ways slightly different between the two countries. So I think the modest increase in infrastructure development within Zambia is possibly something that you feel could have improved upon in Ethiopia, but likewise, actually, the critical shortage of anesthesiologists especially, but also surgeons and obstetricians is possibly more so in Zambia over the last strategic plan than in Ethiopia. And that's something that actually we might look at in one of the subsequent questions looking at human resources for health. From a UTH perspective, Dr. Chanda, how has it felt with regards to the human resources and the aims of the strategic plan within Zambia?
Yeah, thank you very much for giving me an opportunity to speak on this conference. I think one of the issues that really came in when COVID started was that it was very evident that our capacity to manage the critically ill and manage surgery was almost impossible. And the other issue was that we had to split our human resources and cover the COVID ICU that was set up outside UTH. So what was very, very critical again was that the numbers of anesthetists that we have, even before COVID, was critically low. And we also had issues managing our ICUs, managing our lists, and much of the surgeries that we were doing were pretty essential surgery. So we had to break that and really pick those ones that are really urgent to do. And the numbers that we had going to Levy were the ones that we were supposed to do the training, and were the ones who were more senior to manage most complex cases in UTH. So really, this posed quite a bit of a challenge. And one of the issues that we thought we would come up with was to upskill quickly other doctors that don't normally do critical care. And of course, we did manage to get a few, but of course, we had certain specialties that never did participate in that. And we had to use our own very few anesthetists to manage the COVID cases. And compounded with that was the supply chain. Of course, the supply chain has been a problem. Now compounded with COVID, so we generally didn't have many drugs. We had issues with machines, equipment, and many other things just came on board. So my take on this is that COVID was basically an eye-opener to the system, that we needed to invest more in critical care services. And I think looking at it from the perspective of the strategic plan, which it really does spell out how many we need to produce per year and how that should be done. Now, the only issue that I needed to amplify here is that, when we did implement the strategic plan, the issue was that it was not funded at all. I think the formulation was funded by government. Now, the implementation was never funded. So the implementation of the plan has been optimistic, so to say, would ride on other well-funded programs like obstetrics, maternal health, child health. So would fill in there and try and see if we can implement some of our anesthesia plans that we've had. And of course, during the last 4 years, there was so much emphasis on reduction of maternal mortality, and that provided an opportunity to us, for us to fill in and come up with projects that could answer some of our critical questions. I think I'll just give examples here. I think we had the SLAB project, which I felt that did quite a lot in terms of equipping hospitals with reasonable machines that could also produce oxygen at district level. We also did manage to formulate some training programs for our anesthetists in the district. And this has seen quite a lot in terms of the numbers of cases done at district level and the safety profile for the cases done at district level hospital. So my feeling is that moving forward, I think we still need to be very deliberate in the way we train anesthetists. And I think from ministry point of view, we are suggesting that we open up training positions for anesthetists deliberately, and it shouldn't depend on whether people need to choose between surgery, between pediatrics, for example, unless we are very deliberate and train a specific number of anesthetists per year to meet the demand. But I feel that where we are going, the production of anesthetists is so low that it can't match our attrition. I can give you an example. I think in the last 3-4 years, we've lost more than 20 anesthetists, and our production is less than 4 per year. So you can imagine what that means if you lose 20 anesthetists. And the reasons are quite very basic. Things like lack of funded positions. So we are feeling that in the new system, we are hoping that the 11,000, for example, that have been earmarked to be employed, we should be very deliberate, open up senior positions so that we can absorb most of our anesthetists who have no positions at the moment in the teaching hospital. So these are the things that we feel that we need to sit with our colleagues in surgery and speak one language. I think currently the issue that we are having locally would be that we are not discussing. I think that's one of the issues that I think we need to collaborate with our colleagues in surgery so that we can speak one language and try and increase the numbers of anesthetists that we need. And maybe as my last point, the issue of nurse anesthetists. I think it has come up, and we've been training nurse anesthetists for the last 4 years. The numbers are great, but I think it's not being matched by the number of physicians. And this is where we're having a problem. I think it looks quite very good to train many nurse anesthetists. I think from the point of numbers of people to provide surgery at district level. But I think it can only work very well if we train both and in reasonable proportions. I think that's one of the things that I think should be tabled very quickly, because I feel that we are producing more non-physicians than we are producing physician anesthetists. So we really just need to get a plan well done and convince ministry that we also need to produce a certain number of physicians that could match the number of non-physician anesthetists that we're producing. So I thought probably I just needed to amplify that. Thank you.
Thank you very much, Dr. Chanda. Fascinating, and we could actually go on and talk about this for the whole hour. However, I am keen to move on and just think looking back on the last year or 2 years of the pandemic, what have we learned from it? And specifically, I guess, an obvious change globally, but especially in low and middle income countries, has been the focus on critical care capacity, and how that may fit in now with our surgical, obstetric and anaesthetic capacity as a whole. Dr. Mwale, if I can direct that one to you, what do you think we've learned, and what do you think we can take from it if we were to rewrite a new iterations of strategic plans?
Yeah, thanks, Dave, for that question. I think I might hasten to reiterate the value that the National Surgical Obstetric and Anesthesia Plan actually brought in terms of putting anesthesia into its rightful place. So, for example, before the NSOP was developed ever in Zambia, there was little framework around which we could build anesthesia provision of services around. But with the coming of the NSOP, it helped us to, there was a reclassification of hospitals. Also helped us to see what level of expertise was needed at those various hospitals in terms of safety of anesthesia provision, but also the complexity of cases. And so with the coming of the NSOP, it has helped us to put that into perspective and have a basis around which we'll be able to build anesthesia provision around the country. And that said, in addition to what Dr. Chanda has said, indeed, it helps us to see that we need various cadres to provide anesthesia at least levels of hospitals. Of course, the level of hospital, the lower it is, the lower expertise might be needed. And that's why obviously our non-physicians colleagues also come in, and they are probably the majority providing these services in Zambia. And so that also helps us to coexist, but also to collaborate even and more in terms of seeing, bringing the plan to fruition. As regards the lessons that the pandemic has taught us, which we need to kind of feed into the writing or reviewing of the NSOP, is that there are so many gaps that were reviewed. The gaps were in knowledge, infrastructure, as well as equipment. Knowledge-wise, we see that, of course, the majority of people providing anesthesia, like we said, some of them are non-physicians mostly, or nurse anesthetists, but their training doesn't cover much of critical care as they do that. So we find that we have had to improvise in ways of how we can equip them with some knowledge of critical care, and that's why even in our this conference, you've seen a number of projects that are aimed at equipping those people who are taking care of critically ill with the knowledge that they need, but also sometimes with some equipment that we can manage to do that. So that's what the pandemic has also basically taught us. Something else that is also the value of private partnerships. And when I speak about this, I speak about whether you're in Europe, America, or Africa. When the wave was really at its peak, every hospital bed mattered, and every oxygen cylinder, no matter where it was, whether in private sector or where, it all mattered. And now this is where we also exposed. Now we strengthen our public-private partnerships, because then that collaboration became very, very vital in both the referral system as well as the management. We could see that some drugs were available in private sector, but they're not available in the government sector, and vice versa. So that happening also, the lessons were that, you see, we need to see how we can strengthen these public partnerships. And so if we're going to be able to handle the wave that's going to come next, or if it could be COVID or, or anything else. And so that gap, for me, I think that's been a very good lesson for us to see. Now, as we write in the strategic plan, COVID has been a bad thing for us, but as a profession, there's something we can also use to rewrite the plans. Now, initially, when we talked about minimum monitoring, we talked about pulse oximeters, blood pressures in theaters. And that language of high flow oxygen, pulse oximeter might have been strange. But honestly, if you talk about pulse oximeter now, high flow oxygen, even the human resource understand what you're talking about. So you can imagine what this can do for us. If we now are going to be rewriting our strategic plan, we almost, I'm sure we're going to get a bit more support into the anesthesia aspect, because every patient who is a COVID patient, once they get severe, they end up being a critical care patient under intensive care. And that now brings to light the equipment that we need as, to discharge our duties. So I'm hoping that with this COVID, people now have become more aware of the gaps that exist, but also the equipment that are needed to provide, anesthesia, but also critical care to the patients. So for me, I think as we write, that would be a good thing to put in the strategic plan.
So do you think that the government and non-government organizations have actually recognized critical care a little more over the last 2 years? And for those of you that were on the conference this morning, Professor Bruce Bickard was presenting on the COVID critical care study that he led. And as he beautifully said, I think globally there needs to be a greater acceptance that actually, whether it be medical, surgical, obstetric, there's a desperate and holistic need for critical care, but that has to be earmarked and separated from surgical and anesthetic care. Otherwise, it will be swallowed up into already scarce resource. Yeah.
Personally, I agree totally, and I think that's something that we really need to also focus and see that we are well equipped in that area. If, of course, as we talk about the NSOP, it would be definitely very, very important to put it in that aspect as well. But of course, apart from that, this is a profession or an area that has been lacking, not just now, but even for time before today, before the COVID hit, this area was already lacking that.
Arthur, I think you might need to mute yourself if that's okay, please.
Yeah. So that was the point. So now that has come to the fore, I think we need to be a bit more deliberate and a bit aggressive in that area specifically. And that can also change, might mean a paradigm shift in our training. our focus in our training. And even the ones we are training now as anesthesia providers, should we just be giving them anesthesia provision, or should we then probably consider changing their curriculum to include a bit of critical care, because they're the ones providing it in the district level. So this would definitely have to have a bit more focus, and also might mean doing a bit more of changing the narrative in that sense.
Yeah, and obviously the human resource aspects of that will be additional rather than to be incorporated into the needs already. Dr. Munga, from an obstetric perspective, what lessons do you think have been learnt over the last 2 years? Obviously, the maternal mortality has made some significant improvements in Zambia and globally over the last 5 years or so, but I think it's fair to say that COVID will have had some negative impacts. What do you think, what have been the main lessons from your side?
I think the main lessons that we had on our side is basically the importance of critical care. We were used to traditional cases where there are normal cases and normal emergencies. You do your cesarean sections and you do your elective cases, and that's all. But what COVID taught us over the last 2 years is basically that there's more to maternal health than the usual trend. And so what happened was that we ended up having a lot of patients needing critical care more than the usual care that we were used to. There were a few adjustments, of course, like at the University Teaching Hospital, where in particular at women and newborn were able to establish an intensive care unit specifically, aimed at managing the critical cases in our mothers. Now, what we saw is you establish, for example, an additional critical care unit or space or intensive care unit, and you do not have the actual critical care staff that are assigned to work in such a unit. And so everything goes back to the drawing board, that there's greater need actually for critical care in our country as a whole. So what we saw also was that because of the sensitive nature of the outcomes of maternal health, the anesthetic departments really pulled themselves to make sure that whatever little resources in terms of numbers were available, that they could, put towards the maternal health. But we know what that did. It also affected, other usual services, that we always have. And so I wanted to speak to about 3 things. The first thing I think is, how do we get the numbers of the physician anesthetists, being trained? Number one, I am of the view, hello? I'm of the view that during the internship program, our internship here usually runs for 2 years. I am of the view that if in the strategic plan, the Anesthetic Society of Zambia can lobby with the Ministry of Health and the training institutions, that anesthesia and critical care becomes an integral part or a rotation that should be compulsory when our doctors are doing their internship rotations. So what we have seen is that the interest, even for the physicians to specialize in anesthesia, has not been as high as the interest to specialize in other areas like obstetrics and gynecology, as well as surgery, simply because, for people to choose specialist paths of their careers, they need exposure. And so far, what is happening is that during the internship, there's no specific rotation of the intern doctors in the anesthesia and critical care units. I think that would be my first suggestion going forward. Secondly, we need to refocus our human resource establishment at Ministry of Health and government as a whole. What it is that anesthetists have always been seen to be required only in very small numbers. So you find a big institution, but look at the number of positions on the establishment for anesthetists. You'll find it's just maybe 1 or 2 anesthetists in a hospital that may even have about 30 doctors, 30 other, doctors, or maybe 400 other healthcare workers, and the anesthetists on the establishments are only 2 or 3 at most. So we need to lobby that we refocus, the establishment for anesthesia, anesthetists, and critical care teams. I think that would do us a great favor. The other thing again is the positions. Other than the normal establishment, we also need to lobby that even as they create senior positions for all the other fields, I think there should be a deliberate policy to seal off some of the positions for critical care and anesthesia, so that we encourage and drive our friends that have labored so much. Some of them finished training as specialists as far as 2-3 years ago, some 4 years ago, and they are still occupying, junior positions because there are no positions for anesthetists. The other suggestion I would put forward are the issues to do with the training itself and the sponsorship. What we have seen, there was a paradigm shift from the traditional sponsorship of doctors or physicians wanting to specialize to go into specialized trainings. So as we are speaking, the sponsorship is not as available as it used to be. So I think there's need also to re-engage either government or other, cooperating partners to specifically have positions that can be funded, sponsored and funded to train anesthesiologists and as well as, the critical care doctors. What that would do, when the sponsorship is readily available, when the funding is readily available and you're advertising just to attract people to say the funding is available, we need, for example, 20 people to go into the program. Most of the time, such programs usually go through very well. Actually, you can even be overwhelmed. So I think we need to readjust a lot of things. And then the issue also is we increase the trainees. Where are the trainers? Yeah. There should also be a deliberate policy, in my view, Dave, where we can have, for example, scholarships that are aimed in creating a critical mass of teachers in these critical, aspects of healthcare, like critical care and so on. The universities that we have around also, I think, need to be very good strategic partners as these strategic plans are being drawn, so that it's not just from the hospital point of view. Involve the universities, involve the University of Zambia. Is Apex able to train, and so on, so that they are considered as key stakeholders, so that even as they formulate their training programs and so on, everything can be taken into perspective. I think for now, that's what I can say.
That's fantastic. Thank you very much, Dr. Munga. And you merged beautifully into the third point, which was looking at human resources for health. So well done. I didn't even have to prompt it. Thank you. I guess from my perspective, and it's nice to hear that to an extent we're preaching to the converted already, but there is a critical shortage of all surgeons and obstetricians and anaesthetists or anaesthesia providers, and probably within those 3 anesthesia providers are the greatest shortage. There was a 2020 study of workforce tracking that was looking at the goals of 2030 and suggested that even countries like Uganda would be hard pushed to get a density of 4 per 100,000 by 2030, never mind the 20 per 100,000. So I guess my next question that I'm going to put back to Professor Macassar, if I may, is how do we do that? Given the training program for specialists may be a 9-year program in total, how do we now focus on that, looking at strategic plans and factor that in for anesthesia providers or anesthesiologists, but also for the others, and to try and enhance recruitment and retainment? Professor Macassar.
Thank you. So most of the ideas my colleague, Dr. Munga, has actually well spoken on the key things that we could look at in the short term to ensure that we can get to the numbers that we need of the most critically short, the shortfall, the one that we need the most. Like we clearly see, you can see all of us are speaking the same, though we work in different hospitals and in different settings. We don't have enough anesthetists. We don't have enough perioperative nurses. And then we can come to the surgeons and the other cadres. Just to add to what he's already said, that readjustments that can be done to ensure that we have these numbers in the short term. I think that we could also, like Dr. Mwale said earlier, in this country, we do work with health workers that are not physicians that can provide these services. We have a lot of nurses, as you know, a lot of them, and a lot more are being trained, but their career paths are very, very limited. Most of these nurses will only do, midwifery and a little bit of perioperative nursing, but otherwise, usually their career path is quite limited. This is the biggest number that we have. We should look at options to try and see if we can start training these cadres in the specialized field so that they can, they're already trained. It may need a little bit. And of course, they may not be able to serve at a very high level, like in the tertiary level of care, but even in there, it's not all places where you need very, very specialized and very, very highly trained people. If we're going to serve the nation, our focus really should be the district. And at the district hospital, we all know that it's not everything that can really happen there. But the basic thing of doing a C-section, doing a laparotomy, managing an open fracture, and basically life support of critical care in that regard is something that can be managed even by other cadres that we should try and bring on board. And things that we should also, like he said, support the training of these cadres, because we have some schools that are doing that. Most of the time we've not been involved, so we don't know the quality of what's coming out and things like that. So we should do more to try and support these schools as physicians to ensure that we can have more in the short term. But in the long term, of course, yes, we want to have physicians working in these fields, but these other cadres are doing good and we are all fine. Even when I trained, the anesthetists were clinical officers. They were not medical doctors, and we still worked fine. So that's one of the things. The other thing is also, besides strengthening the internship program, what about also just considering accelerating the training? Because like Dr. Munga said, if we can make it the professionals that are graduating aware of the opportunities and also make the funding and scholarships available, we can fast track their training by making them skip the internship, for example. Those that want to do anesthesia and they're doctors, why do they have to do the internship to go into everything else? Why can't they go straight into anesthesia and just train? Because that will shorten their program. Instead of having 5 years before you get an anesthetist, we can skip the first 2 years of internship and have that, so that they can, because they will come and work as anesthetists, and they can, what they learn in the internship is really can be customized to what we are looking for. And there are people that know already what they want to do. So that could be an option as well that could be worked upon. And then, of course, really something that we haven't touched, even through the NSOP, is the same thing that he talked about of establishment. Every facility in the country has an establishment, meaning it has a number of each one of the cadres, this amount of this amount of this. can we now start looking at really service delivery? Our establishment should not be based on planning that is done by people who don't really work in the health sector or who are not medical, who don't understand what we want to deliver at the primary level of care or at the facility. Can the establishment be really based on the service that we want to deliver? And then while we're churning out the numbers, the issue of quality remains a critical issue. There's bad surgery is worse than no surgery. And so while we are increasing the number of these workers, and we're doing that already, we've already, like I said, the quality of and the standards are not that good. These need to be, brought up a little bit more, so that even when we're training not so many, we should still train people that can save life and be safe to the patient, rather than people who are going to create more problems for the patients. Thank you.
Thank you very much. And so I'm aware that we've only got 10 minutes left. I would be keen for any of the audience that have got questions to start putting them on the chat, so we can even just have 5 minutes at the end. I guess one thing that that I'm aware of is that as we've said, we need to increase numbers of physicians in all of those SOA specialties that we've mentioned. We need to think about task sharing and increasing anaesthetic clinical officers in the interim, and try and increase both. But we've also, as you've touched on there, need to ensure that the quality of training is adequate for both cadres. Now, how do you think that organizations like GADP and SAS and the Ethiopian Society, as well as CANESCA, can factor into that? I'll put that to Prof. Tadusu, if I may.
Okay, thank you. Thank you, David.
Just in 5 minutes, and then we'll go to
okay.
questions. Thanks.
Yeah. So definitely, so our collaborators have a big impact in improving all these things. So of course, in the human resource, they play a major role. Even speaking from our experience, our collaborators, our partnership with external universities, they were the major force in improving our enrollment numbers, improving our number of graduates, because we did manage to improve the quality of the teaching, because anesthesia is relatively a new field in our country. So we have new graduates running an anesthesia residency program by themselves. So we need these partnerships to strengthen and to put some quality teaching into the residency programs. And not only, so this can be arranged either with visits or with lectures, but not only that, but it would also be good to build our capacity, for example, through research activities, because this is one thing we are also lacking in experience, and we need to make our practice evidence-based. So in running quality improvement projects and audits and all these kinds of things. The other thing is, again, helping in the simulation. Sorry, am I audible?
Yeah, we can hear you. Yeah.
Oh, sorry, it disconnected from my side. Yes, so that's also one thing we can do. So just building the capacity. And yeah, like I mentioned, simulation is also one big resource for improving the quality for this anesthesia schools and for improving the quality of this anesthesia trainings. So that would be one area. So it's not only with anesthesia, like I mentioned earlier, our major problem right now is, again, with the pharmaceuticals, with the medications, and with the machines. So one training area we have to consider and we have to include is also training our technicians, training our biomedical engineers, and making sure that the equipments are quality and to the standard. So this is also one area of training where our collaborators can play a major role. And yeah.
Fantastic, thank you. I think that's a very valid point, isn't it? That actually it's not just the physicians or the clinical officer or nurse anaesthetist that need training. It's everything that goes parallel to our service provision and to the running of smooth surgical and critical care. Do we have any questions from the audience at all? Christine, have there been any?
Hello, Dave. I think we've had one question, which Dr. Macassar did actually reply to, and it was from Abdul Sata Ravalia. And it stated, one of the major problems we face in Africa is lack of essential health infrastructure and serious lack of drugs and equipment. Africa has the brains and know-how to manufacture these locally. This pandemic has highlighted these problems dramatically. Is it not time for homegrown industries to produce these essential requirements?
Yeah, absolutely. And was that the question, or was there a response to that?
There was a response. I think there have been two responses so far now. Also, Dr. Mwale responded to it.
Do you want
me to read through it?
Why not? Yeah.
Okay. So Dr. Macassar said, yes, Africa should look within and begin to produce what we consume in healthcare. However, we don't have to reinvent the wheel. There is need for the developed world to also walk the talk and put their money where their mouth is by practicing what they preach to ensure equity and help the low to middle income countries set up sustainable options that ensure supplies and equipment are available. This points to issues of technology transfer, something that is always blocked, a red flag to say, in all diplomatic global health engagements. The TRIPS agreement under the World Trade Organization is something that must be actualized if this goal is to be achieved. Low, medium income countries must also come together and develop industry that supplies to the regional markets, rather than each country producing and competing with each other. Our individual markets are small, and our financial investment capacities are limited. Thus, we must try to team up. So that was Dr. Macassar, and then we had a reply from Dr. Abel Mwale. Oh, sorry, that was a question and a reply. So Corina asked, have you got reliable and sufficient supply of local anesthetic agents? And the reply was, yes, we do in Zambia, just the preservative-free ones that may at times not be available due to the short shelf lives. Sorry, I think this, oh yes, okay. So those are the two questions that were there.
And the answers. Thank you very much, Christine. Excellent. Well, we've got 2 minutes, so I think we should probably stop it there, although I would love to carry on and chat to all the panelists, and I'd like to just take this opportunity to thank you all for your time and for coming on and for some really fascinating discussions. I think it will be very interesting to see how the reiterations of the strategic plans go forward, and what the outcomes and the results of actually how we've fared, or how each country has fared with their past strategic plans. But I think I hope that, given the surgeons, obstetricians and anaesthetists on this conference are all singing from a similar hymn sheet, that actually alongside ministries and organisations such as GADP, we can try and do our best to really improve the human resources for health in all of those areas, but obviously from our perspective, particularly anaesthesia, and recognise the importance of everything else that goes alongside that. So the infrastructure, the medicines, the equipment, and the supply chains, and the maintenance of all of those. thank you very much, and I'm sure there will be further discussions about this, and I hope that as panelists you don't mind being contacted in the future with regards to some of your thoughts on how we might take some of this forwards. But thank you ever so much to all of you.